Welcome back to Derm School. Today, we shall continue with our second part on fungal infections. In this lecture, we will look at three conditions: cutaneous candidiasis, pityriasis versicolor, as well as sporotrichosis. First up, candidiasis. Cutaneous candidiasis often affects intertriginous and occluded skin, commonly due to Candida albicans and other Candida species. Here are the risk factors: immunocompromised patients, diabetes mellitus, obesity, hyperhidrosis, warm climate, maceration, occlusive clothing or footwear, as well as the use of glucocorticoids. In candidal intertrigo, patients present with pruritus, tenderness, and pain. On examination, there are pustules on erythematous base, which becomes erosions which are confluent. Patients also have sharply demarcated polycyclic erythematous eroded patches with satellite pustulosis. Sites of involvement are inframammary or submammary areas, axilla, groins, perineal, and intergluteal cleft. This is a picture of candidal intertrigo, and you can appreciate the presence of satellite lesions. When candida is interdigital, this often affects the obese elderly patients. It is also known as erosio interdigitalis blastomycetica. Initially, it starts as a pustule, which becomes a superficial erosion or fissure, and it is often associated with Candida paronychia. Common sites are the wet spaces, especially between the third and fourth fingers, and on the feet you can see macerated web spaces. Other forms of cutaneous candidiasis are diaper dermatitis, in which patients present with irritability and discomfort, either with passing urine or passing motion or with diaper change. They have beefy red plaques with papules and pustules, erosions, and scaling at the margins. This affects genital and perianal skin, inner thighs, and buttocks, and involves the intertriginous areas. Candida also affects occluded skin. Patients can also have follicular candidiasis, in which you have small, discrete pustules in the ostium of hair follicles, and as well as Candida onychomycosis, which we covered in part 1. Treatment of cutaneous candidiasis for topical antifungals. Options include nystatin, azole or imidazole cream or powder. Systemic antifungals include fluconazole, itraconazole, voriconazole, amphotericin B IV for severe disease, and nystatin oral suspension or tablet to eradicate bowel colonization in recurrent disease. Prevention is by keeping the intertriginous areas dry, washing with benzoyl peroxide bars, the use of antifungal powder, as well as antiperspirant gel or spray. The second condition we will discuss is pityriasis versicolor. This is due to superficial overgrowth of a fungus called Melaphysia furfur and M. globosa, and these are yeasts that normally reside in the keratin of skin and hair follicles from puberty. It commonly affects young adults. Predisposing factors are sweating or hyperhidrosis, warm climate or weather, aerobic exercise, oily skin, and application of products containing lipids such as olive oil. It is usually asymptomatic. Patients present with sharply marginated brown to oval macules with fine scaling. These enlarge and merge. Treated or resolved lesions can lack scales. The color ranges in non-tan skin from light brown to pink. In tan skin, it tends to look hypopigmented, whereas in darker skin, it can even be dark brown macules. Distribution is on the upper trunk, upper arms, neck, abdomen, axilla, groins, thighs, and the genitalia. In areas which it can also affect areas where topical steroids, creams, or ointments are used, such as the face, neck, and the scalp. This is a picture of a patient with pityriasis versicolor. Investigations: direct microscopic examination of the scales prepared with KOH shows filamentous hyphae and globose yeast forms, and this is commonly known as the spaghetti and meatballs appearance. On wood slime, there's a yellow-green fluorescence, and you can also do skin biopsy, although this is not commonly done. This is a picture of the spaghetti and meatballs appearance. Topical treatment includes the use of selenium sulfide lotion or shampoo, ketoconazole shampoo, azole creams including ketoconazole, iconazole, iconazole or clotrimazole, as well as terbinafine 1% solution. For systemic treatment, you can use fluconazole 300 mg weekly for 3 weeks or itraconazole 400 mg single dose. Secondary prophylaxis, you can use topicals weekly or systemic agents monthly. Dyspigmentation on the skin can persist for months after the infection has been eradicated. The last condition we'll look at today is sporotrichosis. So this is slightly different from the previous conditions that we discussed because those tend to be more superficial fungal infections, whereas this is deeper. All right. So sporotrichosis is caused by Sporotrix shankai, often due to accidental inoculation of the skin. It is more common in temperate and tropical countries. Transmission is through cutaneous puncture or abrasion, cats as well as from armadillos. Occupations at risk include agriculture, forestry, gardeners, florists, paper manufacturers, and gold miners. Incubation period ranges from 3 days to 12 weeks. It is usually painless and patients are afebrile. There are a few different types of sporotrichosis. The first type is fixed cutaneous, in which there's a dermal papule, pustule, or nodule at the inoculation site. This enlarges to form a verrucous plaque or ulcer with induration, and the draining lymph nodes can be inflamed and enlarged. Common sites are dorsum of the hand or finger and face in children. Next, you have nodular lymphangitis, in which there is proximal lymphatic extension from inoculation site. And here you see an inoculation nodule, often on the hand or fingers, with nodular lymphangitis extending proximally on the arm. Lastly, for disseminated sporotrichosis, this is due to hematogenous dissemination from pulmonary sporotrichosis, and it can affect the skin, joints, eyes, and meninges. This is a picture of a patient with nodular lymphangitis in sporotrichosis. Investigation: skin biopsy for histopathology as well as culture. Treatment is with oral itraconazole for cutaneous and lymphocutaneous disease. You can also use it for patients with involvement of the bones, joints, lung, or even disseminated disease. Saturated potassium iodide solution has been used for cutaneous lesions and lungs, while oral terbinafine can be considered for skin lesions. If more serious infection occurs, IV amphotericin B is indicated, particularly for involvement of the bones and joints, lungs, disseminated disease, and you can even add on 5-fluorocytosine. And lastly, surgery can be used to remove infected areas of the bone or lung. So the take-home message: there are many different types of fungal infections. We need to know the methods of sampling, what the investigations are, and how to treat these conditions. And with that, I thank you very much for your kind attention and have a nice day.